Thank you, sir. It was a very good presentation by Venkatesh Rajkumar. After going through that technical hi-fi procedures, we have to come back to the basics like vascular mapping by ultrasound in AVF. This is very important because first greetings from Trichy. I am from Trichy, which is in the southern part of India, and it's a central Tamil Nadu. So, vascular access for hemodialysis is always an Achilles heel for a nephrologist in view of an advancing age of dialysis population and diabetes. And why we need to have an ultrasound mapping before AV fistula creations, that to be done by a nephrologist. This is a form of intervention nephrology. And why plenty of radiologists are there, why we need to have our own imaging techniques. We know the importance of functioning fistula in a dialysis patient more than a radiologist. We know how it's important. And we also know what you exactly need for an AV fistula surgery. Patient has more confidence on us than on a radiologist and better interaction with the surgical counterparts. And more importantly, the particularity rested by both of a nephrologist and a patient on the success of AVF surgery, because it is actually seal and it's important for the survival of the patient, that gives a definite edge for a nephrologist to do a pre-AVF mapping using a Doppler ultrasound rather than by a radiologist. I'm not against a radiologist, but it's high time that we should take up this for a mapping. In my practice, I've seen that whatever the pre-AVF mapping done by us, the success rate is phenomenal compared to those done by the radiologist. And we all know that these are all the places where we do the fistulas, just like an anatomic snuff marks, that is a low and high radiocephalic fistulas and ulnar and basilic vein fistulas and basilic vein transposition with the radial artery, and Gray's fistula and brachiocephalic. These are all the common fistulas where we do. And why we need to do a Doppler imaging for AVF? We have a very good, excellent video by Dr. Tushar on a physical examination for an AV fistula. But why we need to have a Doppler imaging? That is, clinical examination alone is insufficient in assessing AV access outcome in 25 to 30% of patients. And vascular access procedures and its complications, 25% of hospitalization among the dialysis patients. And preoperative sonographic mapping, more number of patients can be put on the fistulas, increased dialysis adequacy rates. Also, it is that 31% of cases changes in the site of exploration after Doppler ultrasound imaging. And decrease in unsuccessful exploration is 11% against 0% with clinical examination. Increase in the relative number of AVF created as opposed to the other cases of access. And decrease in non-maturation rate, 38% compared to 8.3%. This is a comparison between the clinical examination and ultrasound evaluation before fistula creations. This is a point where we need to do a fistula Doppler ultrasound. And it can be divided into pre-operative and post-operative. And pre-operative is obviously a vascular mapping, and post-operatively it's for surveillance of a fistula and identify the cause of access dysfunction. As this is an elaborate topic, and due to the limitation of time, I stick on with the vascular mapping pre-operatively. In a later session, if Dr. Balasar allows, we can have a separate talk on the post-operative surveillance and identify the cause of access dysfunction. And this is a gist of thing what we need to do for a vascular mapping. And it consists of an arterial system, venous system, and a subcutaneous examination. And arterial system, these are all the parameters I'm going to discuss in detail in the following slides. That is, interarterial diameter, degree of the vessel calcifications, Doppler and all. And this is recommendations by Kedaki that duplex ultrasonography and upper limb arteries and veins are formed in conjunction with the clinical examination in all patients for whom AVF is being considered. This is a clear-cut recommendation given by Kedaki, so it is up to us to do an ultrasound before sending the patient for a surgeon to do a fistula. So this is our basics, Doppler probes. There's a lot of videos regarding the Doppler probes and basics of ultrasound. And you can check it in our Inform website. There's a lot of videos by Dr. Santosh on the basics of ultrasound. Also, it's a beautifully derived videos. And we have two probes of interest. And what we predominantly use for vascular access mapping is a high frequency probe of 12 megahertz and higher. This is ideal for examining the superficial structures. As this vein and arteries are superficial, it's good to use this high frequency probe. And lower frequency probe, that's for lower, deeper structures, is to examine the kidneys and extra. So modalities, we have a grayscale, color flow Doppler, spectral Doppler, and power Doppler. Grayscale is a B mode that we need to use for defining the anatomy of the arteries, veins, subcutaneous area. And color flow Doppler, it indicates the velocity and direction of flow. Spectral Doppler gives you the blood flow volume, peak systolic, diastolic velocity, and resistive indices. And power Doppler, it better visualization of low velocity flows, so small vessels, and low velocity flows is beautifully picked up by the power Doppler, and also it's better for studying the plaque surface morphology. For a prerequisite for a Doppler imaging, the patient need to be placed sitting in a sitting posture. There are a difference of opinions. Some may prefer a lying posture for examining the arterial system, and sitting upright posture for the venous system, examining the venous system. And lying patients will be more comfortable lying down, and we can have a good imaging of the central veins also when the patient is kept lying down. But generally, I prefer to do a scan in a sitting posture, mainly for arterial mapping, for a venous mapping actually. And the room temperature should not be too low. That is very important because of resultant vasoconstrictions, and that may interfere with your Doppler results. And patient should be comfortable, and even it is recommended to have a gel that could be matched to the temperature, room temperature. And you need a tourniquet to assess venous mapping. Simple things. We all have an ultrasound in our hospitals, and it is very easy to do all these things. Just 5 to 10 minutes of examination will do very good for the patients. So before going into the detail, you need to have an anatomy, rough anatomy of upper limb vasculature. You have a radial artery, you have a ulnar artery going, and more important, the superficial venous system, that is cephalic vein and the basilic vein, that both arise from the palmar arch, nasal palmar arch, and there is an antecubital vein that is thing. So this is venous anatomy. You find that this is a cephalic vein that's arises from the palmar arch and goes on the radial side and going laterally, and it pierces the clavipectoral fascia into an axillary vein. So again, this is a basilic vein that also starts and goes and joins the axillary vein. So there is two type of configuration you can get. One is an H type of configuration where you have a median cubital vein arising from bridging the cephalic vein and the basilic vein, and you have a median antebrachial vein coming from the palmar arch. And another configuration will have an M pattern, that is median interbrachial vein that can divide into median cephalic vein and median basilic vein, entering the basilic vein and cephalic vein. And this picture is very important, and this beautifully showing the diameter of vein before and after tourniquet, and before and after tourniquet, and the depth in centimeters from the skin. So coming to the arterial mapping, the mapping should be done proximal to the distal. This is, do not apply tourniquet. Initially, to start with, you start with an arterial mapping because you don't need to apply a tourniquet. Very simple. Structural assessment, that is by B mode. You need to see the vessel wall and diameter. For a good fistula, you need to have a good vessel, non-calcified and expansible vessel, and good diameter vessel. And functional assessment of the artery by Doppler mode ultrasound to show the distantability of the artery and the flow volume of the arteries. What is a more important parameter in assessing the artery is an arterial diameter. So many studies have shown that arterial diameter of less than 1.5 millimeter, the chance of immediate and early failure rates are to the tune of 55 to 64%. So that is a more important thing to see in an arterial mapping. Always see the diameter of an artery. So this is how you should record in your picture. Actually, this is a brachial artery. This divides into a radial and ulnar artery, and measure the diameter of the artery in the different areas, like in a brachial level and the mid forearm and lower forearm level for the diameter of the artery and depth in centimeter from the skin surface. That is also very, very important to make the incision perfect and to avoid other complications that, of incision and all. And very important to have a depth and diameter of the vessel. So this is a mapping of a brachial artery, and you see that this is a brachial artery, and it's not, this is a mid forearm radial artery, and this is a sagittal section of a radial artery. So diameter of the artery should be measured between the inner layer of, between the inner vessel, inner layer of the vessel. You have to measure the diameter, better done by the sagittal plane or by the transverse plane also, to be confirmed with the Doppler showing the arterial waveform. And very important in this thing is your angle of inclination is very, very important in assessing the Doppler flow. So you find that if you put the probe perpendicular to the vessel, your Doppler shift tend to be 0, and you won't get any Doppler shift at all. So the color flow pattern will be very less. So if you have an oblique beaming pattern, that is, you should be like inclination, angle of inclination should be less than 60 degrees. And you find that the same vessel produces a very beautiful blood flow into that. So angle of inclination is very, very important. Always make an angle of inclination, and the beam tracing should be somewhat parallel to the flow of the artery to prevent the thing. Another one important thing to measure, to know, is an arterial calcification. This is very important. You see, this is all the arterial calcifications. Why this is important? Because the arterial distentability will be significantly reduced in the presence of arterial calcifications, and during surgery, and chances of bleeding is very high, dissection is very high. If it happen to get bleeding, there is a chance of rupture and bleeding. It's very difficult to control the bleeding of the vessel when the arteries are calcified. Sometimes we need to have a balloon to secure the hemostasis. So need to calculate the arterial calcification. In this case, if you have a calcified artery, if you know other arteries are available, and if your venous diameter is fine and venous system is fine, and you have to mark the calcified area pre-op so that that area can be avoided during the surgery, and the rest of the thing can be taken for the anastomosis. If your vein mapping is also poor, if your diameter of the vein is also very poor, better to avoid making fistula with this artery. So how to know whether you are dealing with an artery? So also we know that it's a resistant vessel. It has a triphasic flow, and you have a systolic upstroke and a diastolic flow. And this is a typical tracing of a radial artery. You have a triphasic waveforms. So this suggests this is an artery. You need to check this. And one other important thing is, once you find this is an artery, so you confirm the artery, you measure the diameter of the artery, you see the vessel wall for any calcifications or not. After that, you need to identify the hyperemic response of an artery. This is an indicator of arterial distentability. How to do this is to make the hand clinched hand. You put a Doppler probe on the hand, you see the triphasic waveform. Ask the patient to clench the fist for minimum 2 minutes, and ask the patient to release the clenched fist by observing the Doppler forms. If you find that you see this triphasic form, because due to the increased resistance, the triphasic form is more prominent. Once the resistance is lost, there is reflects hyperemic response, the distensibility artery is increased, so that diastolic flow increases, RI comes down. The criteria is if after hyperemic, after you release the fingers, that is hyperemic test, if your RI of an artery is more than 0.7, that means that it's not distending efficiently. It means to say that there will be a complication, that is a chance of primary fistula failure, and also there is a chance of having a steal also. So this is a tracing of a patient where you have a arterial form. This is a triphasic form you're tracing, and once the fist is released, you find that you have a waveform, but the RA is around 0.81. So this is a equivocal one, and if the RA is more than 0.7, and there is a chance of high primary failure rate in this patient, you need to have an other artery to other limb to make a fistula. So coming to the blood volume, do you need to measure the blood flow volume in arteries? Some studies show that successful radiocephalic AV fistula associated with the radial artery flow exceeding 50 ml per minute, and pre-operative radial artery flow of less than 20 ml per minute was associated with increased risk of primary AV failure within the 8 months of surgery. These are all the certain studies, but many studies didn't insist upon measuring the blood flow volume as a pre-AVF mapping of AV fistula. So blood flow volume, this is calculated by the software being installed in the many machines actually. Most of the machines don't have this software. We need to insist on the technicians and the supplying machine company people to insist on putting the software to measure the volume. This is calculated by the diameter of the vessel and the velocity of blood flow in that vessel, and being automatically calculated by the software. So we need to image the artery, and the sample volume should be across the vessel. That is more important. The angle of inclination should be less than 60 degrees. That is very important, because it should be nearly parallel to the flow of the vessel. And you need to have a timed average mean velocity of 3 to 5 cardiac cycles. The average of 3 should be taken for giving the flow of the vessel of the blood vessel. So finally, not the least, is an Allen's test. Clinically, you know how to do an Allen's test. It is very, very important to look for the Allen's test to prevent the subsequent occurrence of steal phenomena and subsequent occurrence of the ischemic gangrene and ischemic neuropathy. Ultrasound-wide, we can do a Allen's test, modified Allen's test that found to be more specific, and two ways of do the Allen's test by ultrasound. One by imaging the palmar arch and occluding the radial artery. You find before occluding, you find the Doppler flow of a radial artery towards the flow. Once you occlude the radial artery, there is a reversal of flow in the radial artery due to the collateral supply from the ulnar artery. So presence of this indicates as a patent ulnar artery. Another way to do is to place a probe in the radial artery and observe the waveforms, observe the Doppler flow, and you press the thing proximal to the probe, you just press the radial artery, and if there is a reversal of flow, that means if your red color changes to blue color, that is away from the flow, it means that there is a collateral circulation, that is the blood flow is being filled up by the ulnar artery, mentioning that the Allen's test is negative. Then you can go ahead with the doing fistula with this radial artery. These are all the things we need to know about the arterial mapping of pre-AVF. Then comes to a venous mapping. Venous mapping, we need to do a B mode and Doppler. B mode, there is a lumen diameter, pre and post tunicate, condition of the vessel wall, as in case of an artery, and look for the venous tributaries is very important. Compressibility of the vein, course of the vein, and distance of from the skin. These are all the important parameters which will give you the clue that this fistula is going to mature or not. And Doppler, very important to do the phasic variation. So again, I'm posting this picture. This is a beautifully driven picture. You need to measure venous diameter pre and post tunicate and also the distance from the skin. So this is the various level of cephalic vein measurement at various level. This is at the elbow level. This is a mid. This is at the mid-arm level. This is a forearm level. This is the 3 levels we have to see the vein, and this we have to need to see the compressibility. Compressible vein indicates that vein vessel wall is a vessel is a vein is patent, and that's very good for doing a fistula. This is a cephalic vein on the forearm, and we need to compress and see this beautifully is compressing. This is the vein is beautifully compressing, indicating there is no hidden thrombus within the cephalic vein. And we need to see the thickening, wall thickening in the vein to identify that there is a previous phlebitis, and whether you need to see the vessel wall also for mapping. And a normal Doppler of a vein will show a respiratory phasic variation. If a phasic variation, if you're able to appreciate the phasic variation throughout the course of a cephalic vein, it indicates that proximally there is no obstruction, there is no distal obstruction of a vein, and it's safe to do a fistula in this thing. Always never forget to see the central veins, and mainly it is in order to prevent the mishappening after the fistula creations, like venous hypertension, and as previous speaker told about that subclavian syndrome and all. So this is a normal subclavian waveform. We need to do a waveform, Doppler imaging of the central vein, and after doing a respiration, ask the patient to take a deep breath, there will be a phasic variation of the vein waveforms. If there is no phasic variation, you find that this figure shows that there is no phasic variation, indicating there is a distal stenosis or obstruction in the artery. There is no decrease to the baseline of the wave with the respiration, indicating there is a proximal stenosis. Never attempt a fistula unless you do a angiogram to see the central veins. So Doppler criteria for a good outcome: diameter of at least 1.6 centimeter of a peripheral artery, presence of an hyperemic response, patent hemorrhage is very simple, and peripheral veins 2 millimeter without tunicate and more than 2.5 millimeter with tunicate, and presence of respiratory phasicity in central veins. These 3 things are very good enough to know about the success of the AV fistula, and you can straight away send the patient for surgery, or you can do it. So finally, you need to do the veno-arterial distance to plan for an incision and mobilization. And many times this is being missed by the radiologist. So sometimes there will be a distance will be wide apart, that radial artery and cephalic vein will be placed wide apart. And we need to do 2 incisions to make the mobilization of the vein and all. So always measure the arterial and venous distance wherever you need to make a fistula. Here this is around 5.9 millimeters, and this to be written, and it should be made in a diagram so that the operating surgeon or an operating nephrologist will have an idea about the vein and artery. So once it is being done, this is the important thing about the mapping of a arterial venous mapping of before AV fistula. Once it has been done, different studies have reported AVF non-maturation rates within the first months after creation from 5% up to 54%. This is an interesting paper that shows that prior to the surgery, the blood flow volume is around 20 to 20.9 plus or minus ml per minute. Once the surgery gets completed, the blood flow rate phenomenally increases from 120 to 174 ml per minute. One day post-surgery, it went up to 754 ml per minute, and 7 days, it is 799 ml per minute. This is in the artery or vein. Okay. So 42 days after surgery reaches around 946 ml per minute. You can do assess a blood volume immediately after the surgery is over or when a day after to assess the maturation also. There are papers suggesting also. Once a successful fistula has been done, what we expect in a Doppler ultrasound in an AV fistula. The feeding artery, which is triphasic flow, becomes a monophasic, which has a large diastolic component because the peripheral resistance has gone. Whatever the blood flows goes into the fistula, so the resistance of the artery comes down drastically. And very turbulent flow across the anastomosis, suggesting this is a good anastomosis. And draining vein will have a pulsatile flow, that is arterialized vein. We have a systolic and diastolic wave with a minimal resistance. And if you measure the volume, it should be more than 500 ml per minute. Over the time, there will be a distension of the feeding artery and also the draining vein due to the consistent increase in flow of blood. This is how the brachial artery looks after doing a good fistula. After brachiocephalic or radiocephalic fistula, you find that this is a low resistant flow. We have a good diastolic flow in the artery itself. And in the vein, you have a similar biphasic flow across the vein also. This is an arterialized vein. We will do if you find the RI, it will be around 0.4 to 0.5. And this is how the turbulence look actually in the anastomotic side. This is the tracing of the anastomotic side, the waveform. You find a beautiful biphasic flow across the anastomotic side. So once the surgery is done, simple way of assessing the sonographic maturity, this is going to develop good, is like the vein should be more than 0.4 centimeter, that is 4 millimeter, they should distend more than 4 millimeter. The depth of the vein should be less than 0.5 centimeter from the skin, and flow volume should be more than 500 ml per minute to suggest that this fistula is going to work fine. Because venous diameter of more than 4 suggests 89% adequacy, and flow volume of more than 500 ml per minute again shows 84% adequacy. If both criteria is met, that is 95% adequacy, you don't worry about the failure of the fistula. And thank you for patient hearing. I just gave the introduction how to look for the mapping of fistula vessels before AV fistula and how the hemodynamics changes takes place. And regarding the surveillance and the assessment of the AV fistula dysfunction, and this is again a big topic that can be dealt in the later slides. Thank you for the opportunity.
Sir, you are muted.
Thank you, Rajarajan. Now let us all welcome Dr. Tushar, who has joined us with great difficulty in between his work. Please, Tushar, you can start. You can. Tushar, yeah.
Yes, so I wasn't sure what you wanted me to do because I have not prepared any presentation. So
yeah, I mean, you're chairing this session where he was describing the mapping, and more than all that, I wanted to show off to my audience, Tushar, and and sort of let you know that this is going on and how you should encourage.
Thank you so much, Bala, for inviting me. I mean, I know I goofed up initially. I mean, I got called into the ICU. This is a new service I have started here at Cleveland Clinic, where I'm helping out in the ICU with all tunnel lines. I don't put any non-tunnel lines, only tunnel lines in the ICU. And certainly this what you have started, this forum, I think it's a great initiative to bring in the younger generations and also bring in the camaraderie of all the multidisciplinary people who are involved in improving vascular access care in India. And I think your forum certainly is unique in the sense that that it is interactive, and I think that really matters most, because as people start doing things and practicing on their own, there will be questions, and bringing in experts certainly helps answer those questions. So I was listening to Dr. Rajarajan's talk, and it was wonderful talk. So great presentation. And I'm happy to be part of this. Thank you again for this invitation. And I'm going to sit back and listen to the people who are going to present. And obviously, if there are any comments, I will certainly chime in between.
Yes, Tushar. To start, see this mapping and things which he was describing. Is it a routine practice in your place? Is all patients venous mapping done? If so, who does the mapping? Is it the nephrologist or the radiologist or the surgeon?
So yeah, mapping is done. Definitely, mapping is done. Again, different centers practice differently, but centers where I have worked, mainly the two centers at Wake Forest University and now here at Cleveland Clinic, we do the mapping. Mapping is done primarily by the radiologist, but the surgeons will always do it again in the operating room. And one point that Dr. Rajarajan mentioned, which I think is very crucial about tying a tourniquet and seeing the distensibility of the veins. I think that's a key point, especially after the regional block, when you see that sometimes the vessels that are missed by the radiologists often become significantly distended and are utilized by surgeons to create an AV fistula. So oftentimes when the patient goes in for to a radiology office to get the vascular mapping, they may be dehydrated, or a general blanket instruction is given to them, keep NPO. I mean, you don't need to be NPO for this. They come in NPO, they may be dehydrated, the room may be too cold. For whatever reason, the distal vessels may not necessarily distend as much. But once they are in the OR, after the regional block, after a tourniquet, the vessels distend, and the surgeons do find places where a good surgeon definitely will find a place where an access can be created. So yes, it's done by radiologists, but also reconfirmed by general surgeons or the vascular surgeons. Nephrology per se, we generally don't get too much involved here the way the system is. Most nephrologists are not doing AV fistula, so they're not, unlike what you do and a lot of nephrologists do in India. We do ultrasound of the access only after the access has been placed and either it's not maturing or we run into trouble.
Okay, I think that answers my next question was the likes of us who are doing AV fistulas here. I mean, aren't there much people there doing fistulas, nephrologists?
There are very few nephrologists doing fistulas. And again, those who are doing it essentially have had some surgical background from wherever home country they came in. So they are more comfortable doing it. Credentialing is a problem. And OR time is a problem. So certainly it's not, and yes, medical legal liability is a big issue too. So not many nephrologists. I can count a handful, no more than 10 probably in the country.
I see. Then when nephrologists are trying to do AV fistula, I think this mapping becomes very important because everybody is looking over your shoulder, how good you are, what is the success rate and all that. So the likes of us here in India who are trying to do fistulas, I think it is very important and imperative that we undertake mapping and things like that so that we don't get into trouble taking up cases which would not succeed. I think that was one reason this talk was chosen for today.
Yes, I think that's a great tool to have. Again, unlike here, I know there are places in India where people perform, the nephrologists are performing AV access surgeries in smaller rooms, not necessarily a big OR. So you have flexibility there, and if you have ultrasound is a reasonably cheap tool now, so why not use it and take advantage of that diagnostic tool?
Then Rajarajan, checking the blood volume flow, especially after the AV fistula, you should tell us where you do it. It's in the radial artery or in the brachial artery. I think that point should be told clearly to the audience.
Yeah. There are two ways of doing the blood flow volume assessment, sir. Pre-AVF mapping, it's not necessary to look for the blood flow volume. Actually, many studies didn't quote for that. That doesn't support the maturation of fistula. Only in case of access dysfunction or the maturation, assess the maturation, we need to do a mapping, either blood flow volume. There are two thoughts. One, you can do with the feeding artery. Volume vessel, blood flow volume can be measured in the feeding artery. If you do a radiocephalic fistula, you can still measure the blood flow volume in the brachial artery because it's a good caliber artery. It is resistant for your compression compared to the veins. Because there's a diameter and radius is very important because of the Poiseuille's law. When you mistake the diameter radius, your velocity blood flow will go haphazard because it is a flow is directly proportional to the fourth power of R. So preferably artery is better to look for the blood flow volume measurements as against veins due to this constraints. I perform a blood flow volume on the brachial artery even if you do a radiocephalic fistula to assess the blood flow volume. Or if the radial artery caliber is good, you can do a blood flow volume assessment of the radial artery. If you want to do it in the vein, it should be in the mid, away from the anastomosis. That's the mid-arm vein where you have a straight, the vein course should be straight, it should not be tortuous, and there should not be any tributaries arising from the vein. You need to identify this area and to measure the blood flow volume. It's better to assess the volume in the artery. And there is a difference actually. If you have, we can have a differential diagnosis how to identify the problem with the blood flow volume. If you have the blood flow volume of afferent artery more than the efferent vein, there is a problem in the anastomosis. This is for a maturation of fistula actually. If your blood flow volume in the efferent vein is more than the efferent artery, that means that there is some amount of steel is going on. That means there is some tributaries going out and there is steel is going on. And if the efferent artery, efferent volume is less, very less, it means to say that there will be a both of artery and vein both are less. It means to say there is a problem in the central vein. So if your problem, if you are analyzing the blood flow volume for the access dysfunction, it has to be measured in the artery and the draining vein. If you want to assess for the surveillance purpose, it can be measured in the artery itself.
Great. And I think we'll have to mention here that the formula for calculating the volume is such that if you make small variations in the radius of the artery, that will make huge difference in the volume. So yeah, one has to be very meticulous in
assessing the.
And any comments and questions from others? Dr. Velaravan, you want to add anything?
I'm perfectly fine with Rajarajan's talks. It's very wonderful. So actually, he covered everything. But one aspect I'm really worried, sir. Patients already on left side, a catheter already, patient is on catheter. That's why if you're asked to do a fistula, that's the issue always. The phasic variation, we can not only the central vein phasic variation, sometimes obese patients is very difficult to measure, sir. Start from the mid-arm, you can see the phasic variation. Yeah. What I find over the years, 150 years fistula in a year, almost I covered 3,500 fistula, and that what I've learned, my fingers are the best ultrasound. First, I ask the patient to sit in my office, whether he is taking any drug which is causing bradycardia, like less than 50 heart rate, I will not take. More than 60, it's well and good. And no partial hypertension. Patient, if we see to that, there is not taken morning dose of antihypertensive. The moment you do the fistula, after patient getting out of the OT table, then stands up, momently it stops. All these things I'll take care. This is the first point. Second, artery assessment, as he said, what he has covered very nicely. And if the monophasic flow, I'm really worried. And any elderly patients, both the male and female, diabetic individual, chronic smokers, going to the brachial fistula, I always be a little worried about the distal part of the circulation. This always keep in mind because I had one patient, critical limb ischemia, I had a trouble. regarding the phasic variations, patients, if our patients, most they are dyspneic and they cannot hold breath and things. What I suggest to the beginners as well as the people are doing already, very simple point. You just trace the vein from the peripheral to the central across both the basilic and as well, whichever the vein you want to do. Cephalic the vein has got a lot of valves actually. If a patient has got a proximal stenosis, like a central vein, even if a patient has got a partial obstruction, the phasic variation may not give you an idea, but this point will give you an idea. Like I do a lot of echo. Whenever you have LV dysfunction, the mitral valve will not open. Like that, we can like the same phenomenon we apply here. You just trace the vein from distal to proximal. You see the collapsibility by just compression. That's one point. Another thing, the valve, how it when the flow towards the heart from the vein, it goes. The valve should approximate. It close touches the valve will touches the wall. Valve will touch the wall. That means the vein is opening nicely. If there is any kind of a proximal stenosis, the distensibility will not allow the valve to open completely. This finding, I find it extremely useful in a patient already on a left side catheter, right side catheter, whichever the way, and the patient's already on catheter if I'm going for a fistula. So rather than a phasic variation, sometimes our patients cannot hold breath and they're always dyspneic. So many times I miss it, but this finding helps me a lot. It's only complementary finding, but otherwise, he has covered everything nicely. And well, it was clinical examination very important, sir, because I've you started doing fistula much earlier than me, but I'm doing last 20 years. And so that now the people are more worried about, I mean, without mapping, they will not touch. But I was doing fistula without a vascular mapping, almost 90% success rate. But now it gives you more confidence that before doing a fistula, if I do mapping, 100% I'm sure that I'm going to be successful. Otherwise, on table, I'll judge certain things. But now the era of all medical legal issues and other things, we have to teach the younger generation with the scientific gadgets and other things. So mapping is important, and a lot more to be learned over the time of experiment doing fistula. The person doing fistula, I mean, if mapping and doing fistula will have more comparison than reading some report from radiologists and doing a fistula. It makes a lot of difference. I think Raj touched it nicely, and this is one point I added, so the phasic variation point.
Yeah, plus AV fistulas done by nephrologists. When I met Tushar and people in Asdin, I mean, we don't tend to keep a record of the cases we do. We know that we have done a fistula and it works once you come out of the theater, and I think you think it is success. So that way it will be 99 to 100% success. Only 1 or 2% will not work once you come out of the theater. So when I try telling this to people, and when they hear from them that their results are less than 60% success rate in fistulas, then I realize the difference, because when you just consider the success when you leave the theater and the number of patients who are successfully cannulated after 2-3 months, when you take up for dialysis, I think there is a lot of variation in the numbers. So for that, I think this mapping and assessing would help you, pick up cases which will ultimately succeed. So it is not merely, fistula with bruit at the end of the surgery.
Bala, can I add a point
Yes.
to what you just said? Yes, at least here, and you guys are familiar with the literature from here. And you mentioned about the mapping and the success or primary failure rate. I mean, the biggest study from NIH, the Dialysis Access Consortium study, where all of these points were considered. Every site was using mapping, and even then, the primary failure rate was about 60%. So yes, I know. You guys have. I mean, as nephrologists, when you do it, you have a much higher success rate. But I think it would be really nice if somehow you can collect that data and publish it. I mean, for 20 years, if you've been doing it, and if your failure rate or primary maturation rate, failure rate is less than 10%, I think that's just phenomenal, and that really needs to be highlighted in literature.
Yes.
I know it's difficult with the clinical time and the resources. It's hard, but I think collectively, at least now that you've started this forum, maybe one of your objectives should be to start collecting data and have a central repository where people enter in their, as soon as they do their studies, they enter in and provide maybe 4 weekly or 3 monthly, some kind of an input.
And any other questions or comments for the other talk on catheter dysfunction? Dr. Lobo, you want to give any final comments on that?
No, I think I made my points earlier in the discussion in between the two talks. So I think, again, the same thing where catheters, we are all concerned. In our unit, for instance, a few years ago, our use of catheters was about 10%, and now it is 22%. So clearly catheters are there to stay, and so we need to use them better. And what we are doing is to try and see why we are using so many catheters. That's one of our students' thesis topics now, and see how many of those catheter patients we can convert over to AV fistula. So that's important. And the other thing is monitoring. What Tushar just said about getting it down, documentation is where all of us fall behind. In busy times, we don't document, we don't collect. And something that happens is, which I've learned from personal experience, we tend to remember our successes and we tend to forget the failures. So that's why documentation is the most important thing, because then we'll get a true picture. That's all.
Yeah, otherwise there is a selection bias, and then you tend to keep thinking about all your successes, like you said, Rally. So doing it more scientifically would give a much clearer picture.
I think we'll take it from you and start creating, there are only few of us doing fistulas. We can have a protocol and, the definition of primary failure, secondary failure and all that. And I think we'll try to collect data and get a realistic picture of our prowess. Or,
I think you have this now. Just create a cloud-based Excel sheet and just keep entering it. And maybe at some point you will find somebody who will be able to analyze it, maybe 2 years down the road. So,
because precisely, I was also, having a great false thing about my thing, because I was confined to only looking at the result at the end of the surgery. So let us see, we'll work on that and come back to you with Indian data.
Yeah. And the definitions, well, the definitions are all there. You just have to pick up the NAVEX document from seminars in dialysis, and there's a uniform definition for everything. Primary failure, what is clinical success, what is clinical patency, all of that is there. There are about 50 definitions over there.
Right, we'll allot somebody, and I think we'll start collecting data from ourselves. Okay, I think Sampath. Yeah.
No, I am dumbfounded by the presentation and the discussions. So I'm just a listener now. Yes.
But I'm not getting juniors and freshers asking questions or clarifying things. There is no questions in the chat box either. But the website is on, and I encourage people to, at least your problems will be taken up for discussion in the forums, and some seniors can answer them definitely. Especially today we discussed about different people having their own regimens for declotting, and we'll have to learn from each one of them. I think that's the way we grow. It is not always from books. So let me thank everyone, Dr. Lobo, Dr. Tushar, Dr. Hemant, and Dr. Rajarajan, Dr. Venkatesh, and all the people who came for the meeting. But I wish more and more, feedbacks for me, so that, and what I'm thinking is, after a few meetings, I would make somebody sort of to take up one meeting and consider the topics, arrange the speakers, so that way that will involve, because I wouldn't know who are all doing good in different places of the country. So I'm thinking something on that line. I think Hemant and Lobo from North should be able to pick up more people who are active in intervention nephrology. Thank you once again. Yes.
Can I ask one question, JB?
Yes.
With so much interest now there, have you identified sites where people can train?
Sites
I know
where
I know you have been training people, but I get requests from India, and I know there are so many people doing these procedures. So why should they even go to another country and try to learn? I think there is enough opportunity within India now. Where when we first met, I think 15, 20 years ago, it was new, but I don't think now, I think India is way up there. I think there are so many places, so many experts out there. There's no reason for the new generation to try and look for training sites outside India. I mean, within India, they will get hands-on training. If they go out, all they'll get is observer's position. I think it doesn't serve the purpose.
But remember, Tushar, you are considering some form of accreditation to centers which can give training, because there is no system here.
I think CMC Vellore has started a course which is accredited.
Yeah. So
Dr.
yeah,
Santosh
there should be more centers who are accredited, and there should be a system how we should be. I think they went through the Madras, MGR University here. If ISN itself, or I don't know how it works in US, but I've been trying to ask people from various places the methodology where we can accredit centers so that anybody trained in that center would be ethical. Because one of these meetings, it is going to be on the problems how people face trying to do interventions. It will be there in the next few months. So that is the time we'll be able to discuss, and there are very funny situations where they are objected by the surgeons or the hospital management. I know one boy from Vellore where he was given quota. You can do only radial AV fistulas, not elbow, and only 2 PD catheter insertion per month and things like that. So how to get around all this? I think we need to put our heads together, and we'll allot a meeting for such discussions in one of these months. Yes, thank you. Then I think we'll stop here.
Yeah.
And I'm glad so many of you got involved today, and we'll call it a day. Thank you. Thank you, Tushar.
Thank you, sir. Thank you.
Great seeing everyone.